Nishant Sahay to take over the thing. Nishant,
Yeah.
please go ahead.
Yes, sir.
In the
Thank
meanwhile, Dr. Dipti, please stop sharing the screen for the moment.
Okay.
Good evening, everyone, and very warm welcome to the ISA online PG classes. The ISA has been having these PG classes since July of 2022, and
COVID time.
21.
yeah, and teachers of repute are spare their valuable time and effort for the benefit of the postgraduates. And today is no different. Today we have Dr. Dipti Saxena ma'am, who will be discussing a very, very important topic on pulmonary gas exchange, the oxygen and carbon dioxide transport. This is the 79th class from this series. And Dr. Dipti ma'am is a professor and head of the Department of Anesthesia at the Sri Aurobindo Medical College and PG Institute at Indore. She has many publications in national and international journals, and her special areas of interest include neuroanesthesia, oncoanesthesia, bariatric anesthesia, and anesthesia for organ transplant. And to chair this session, we have another stalwart, Dr. Sadhna Sanvatsarkar, madam. She's the Dean and the Professor of Anesthesiology at the LNCT Medical College and Sevakunj Hospital, and she's currently the President of the ISA Madhya Pradesh Trade Branch. She has special interest in pediatric anesthesia, critical patients for anesthesia, and regional anesthesia. And she's been a PG teacher for many years, more than 20 years, published many articles in various journals, and we get to see ma'am quite often in the various conferences in various capacities. So a very warm welcome, ma'am.
Thank you so much, Nishant, for the very
Thank you.
nice
Thank you, sir.
introduction. So
Yeah.
I welcome Dr. Dipti to present her topic today.
Thank you. Thank you, ma'am.
All the best, Dipti, for the presentation.
Thank you. Thank you, ma'am. I will start my screen sharing.
Yeah, surely. Sure, please.
Okay. A very good evening, everyone. At the very outset, I would like to thank the organizers for giving me this opportunity to speak before you a very important topic, especially for all anesthesiologists, which is pulmonary gas exchange and transport. Now, at the outset itself, I would like to define our learning objectives. Now, we will start with discussing the pulmonary gas exchange, which comprises of three very important processes, that is ventilation, diffusion, and perfusion. We will also be discussing the transport of oxygen and carbon dioxide in blood from lung to tissues and vice versa. Now, I will also be discussing the relevant clinical implications, although I will discuss it then and there instead of discussing it at the end. So let us begin. In normal conditions, in order to understand the physiology of gaseous exchange in normal lungs, we have to understand that there are actually two interfaces that the oxygen and carbon dioxide, let us say, should cross. The first interface is actually at the lungs, where alveolar capillary membrane helps in exchange. And three important processes define this transfer, which includes ventilation, diffusion, and perfusion. The second interface is at the level of tissues, where the cells and blood cells produce carbon dioxide, and from there, the carbon dioxide is released in the blood through perfusion and diffusion. So mind you, the ventilation part is peculiar for lungs. And all these three processes, actually, they come together and they follow the principle of conservation of mass. So let us start with the first and foremost thing that happens for gaseous exchange. It is ventilation. Ventilation is actually a process of movement of inspired gas into and exhaled gases out of the lungs. It is a continuous and cyclic process which requires energy and is determined by metabolic demand. It is mainly dependent on rate and depth of respiration, and it is because of this that we come to an important important word, that is minute ventilation or concept. It is the product of tidal volume and respiratory rate, and the normal range is about 7 to 8 liters per minute. Let us look at the composition of the inspired and expired gas. This is also very important. Now, I will tell you why. The composition of inspired gas includes nitrogen, which is 79%, 21% of oxygen, trace of carbon dioxide, and variable water vapor. Now, while the expired air is constituted by nitrogen, which is again 79%. This shows that nitrogen does not take part in gaseous exchange. It is oxygen, which is reduced to 16%, carbon dioxide, which is increased to 4%, and water vapor, which is saturated. Now, this shows that carbon dioxide, this is because carbon dioxide and water vapor, they are the end products of metabolism. So they are thrown out of the body through the expired air. Now, in this slide, I have introduced two very important topics. One is fraction of inspired oxygen. Now, the fraction of inspired oxygen, as we can see in the slide, is 21%, because the composition of inspired air shows that oxygen is 21% in inspired air. Now, general anesthesia normally causes impaired oxygenation of blood due to various reasons, which we will be discussing in the slides later on. So FiO2, which we prefer in general anesthesia, is actually 30 to 50%. So we are introducing an important concept here, that is of fraction of inspired oxygen. So what we do in general anesthesia is we try to increase the fraction of inspired oxygen. Okay. Now, the second very, very important concept is that of pre-oxygenation, or in other words, denitrogenation. So as we can see that in the inspired air, there is 79% of nitrogen. Now, this 79% of nitrogen, if it is replaced by oxygen, we can actually increase our oxygen reserve, which is the most important reason why we do pre-oxygenation. Now, the endpoints of maximal pre-oxygenation, that is, what is the efficacy of this pre-oxygenation? The end tidal oxygen concentration should be of 90%, and end tidal nitrogen concentration should reduce to 5%. Now, I haven't gone into the details of pre-oxygenation, but this is a very important topic that you should be familiar with. Now, once we inspire, the gases pass through the nasal cavity or oral cavity to pharynx, larynx, and to the lower respiratory tract via trachea, bronchus, bronchioles, to terminal bronchioles, and finally alveolus. But the gas exchange actually takes place only in the alveolus. So the rest of the spaces actually constitute the anatomical dead space, which is constituted by the large airways till terminal bronchus. So they are only the part of conducting zone and not of respiratory zone. They do not participate in gaseous exchange and constitute about 30% of the tidal volume. So 30% of the tidal volume is lost to the conducting space. Now, during anesthesia, when we are using face mask, when we are using the circuit mouthpiece, all of them constitute the dead space, and which is known as the apparatus dead space. So this is very important that we reduce our dead space at the time of mechanical ventilation. Otherwise, it will hamper the pulmonary gas exchange. Now, what are the benefits of having this anatomical dead space? There are certain benefits as well, because the air that we inspire is very dry. It may be full of infections. So all these things need to be curbed down, which happens by conditioning of the inspired air through warming, humidification, and filtration. Now, there is certain of alveoli. They also act as dead space. Why? Because there may be some alveoli which are not getting ventilated, and some alveoli which are not getting perfused. In both the conditions, there is functional or alveolar dead space. In normal conditions, functional or alveolar dead space does not exist. But in certain diseased conditions, it does, like atelectasis, COPD, pulmonary embolism, hypotension. In all these conditions, there is certain amount of alveolar dead space. Now we come to the important aspect of dead space, that is physiological dead space. It is nothing but the combination or the sum of the anatomic dead space and functional dead space. Now, this concept is important because what we actually do when we do capnography is we are actually measuring this dead space only. Now, another important concept here that we need to learn is that now since the gaseous exchange occurs only at alveolus, the amount of air, the certain amount of air remains in the alveoli in the form of closing volume. And if we are in the resting state as functional residual capacity. Now, this air actually does not participate in gaseous exchange. So when fresh inspired gas reaches alveoli, this gas mixes with the fresh gas and reduces the oxygen content of the inspired air. So actually what we are seeing is 21%, but the actual concentration of oxygen in the alveolus is less. So now, portion of the minute ventilation that is actually participating in respiration is what is known as alveolar ventilation. This is a very important concept. And if we want to find out the alveolar ventilation, we have to deduct the volume of dead space from the tidal volume. So the equation that comes out is alveolar ventilation is equal to respiratory rate into tidal volume minus the dead space volume. Now, this alveolar ventilation is actually influenced by two very important phenomena. One is the respiratory mechanics, which comprises again of two things, compliance and resistance. Now, I will not go into the details of this respiratory mechanics because it is not possible to cover in this lecture, but I will be discussing the perfusion later on. But one important thing that I would like to mention here is that now this respiratory mechanics, which comprises of compliance and resistance. Compliance is basically the opposite of elastance, that is the property of the tissue to regain its shape. It is just the opposite to retain its shape. And resistance is the air which is not able to. It is actually because of lack of flow. The stoppage of flow is mainly responsible for the resistance. So compliance and resistance are two very important phenomena, respiratory mechanics. And it is this which determines the regional distribution of alveolar volume, alveolar ventilation. How we will see in later slides. Now, the respiratory zone of the lung is what comprises the alveolar ventilation. It is made up of respiratory bronchioles, alveolar ducts, alveolar sacs, and alveoli. Now, there are small openings in adjacent alveoli that allow for collateral airflow and equalization of pressure between alveoli. This is important and prevents trauma to the alveolar space if there is increased ventilation. Now, the alveolar septum through which the gas exchange occurs is made up of numerous capillaries and thin walls for gas exchange. Type 1 pneumocytes that are very thin and line the alveoli. Type 2 pneumocytes that secrete dipalmitoyl phosphatidylcholine, which is the surfactant to decrease the alveolar surface tension, and alveolar macrophages, also known as dust cell, for defending against pathogens and irritants. Now, this is very important. Next slide is again important from the student's perspective. Bronchopulmonary segments come as short notes in the exam. Now, it is actually the portion of lung which is supplied by a specific segmental bronchus and its vessel, and is the largest functional division of anatomical lobes. It is supplied by a segmental bronchus in two arteries, pulmonary artery, bronchial artery, which run together through the center of the segment. It is important from the point of view of surgeons mainly, because if they are resecting the parts of lung, they go along with the bronchopulmonary segments. Because if a bronchopulmonary segment is removed, normally the gaseous exchange in other segments is not hampered. Now, physics related to respiration is very important topic, which actually can be taken separately, which requires a lot of work. But I have included this slide here because I would not have been able to explain the physiology of pulmonary gas exchange if I wouldn't have elaborated these laws. So the first and foremost law is the Boyle's law. Boyle's law, which states that volume of a gas is proportional to, or is inversely proportional to the pressure of the gas. And it is this law which is responsible for movement of air into the lungs, because as the gas enters the respiratory tract, the volume of the gas is reduced and a pressure is built along which which gradient this gas moves inside the lungs. Second important law is Dalton's law, which states that total pressure of a mixture is the sum of partial pressure of constituent gases. It helps in calculation of arterial blood gases as well. Third important law is Fick's law, which states that volume of gas transferred per unit time is directly proportional to the surface area for gas exchange, partial pressure difference of gas, and inversely proportional to membrane thickness. Now, this again is a very important law which determines the factors which are responsible for diffusion required for gaseous exchange. Fourth and important law is Henry's law, which states that amount of gas that dissolves in a solution is directly proportional to the partial pressure of the gas. This explains the amount of gas that is dissolved in blood, and this is very important from the point of view of decompression sickness. Now, what happens as we go to higher altitudes, more and more amount of nitrogen gets, because of increased partial pressure, the more and more amount of gas, because of decreased partial pressure, more and more amount of nitrogen starts entering the, it leaves the blood and enters the plasma. It leaves the plasma and enters the tissues, leading to embolus, so which leads to decompression sickness. Now, I have one important food for thought here. Now, we travel in planes. Why don't we get decompression sickness? I think all of you can answer in the chat box.
Yes, ma'am. So all the listeners are currently muted. What they are encouraged to do is
they can answer in the chat box.
Chat box, yes,
so,
yes.
Because this decompression sickness is an important aspect, and it follows the Henry's. It actually follows the Henry's law. So I think they should be able to answer.
Could you repeat the question again, ma'am, please? What?
My question is, now we travel in airplanes also at very high altitude. Why don't we develop decompression sickness? Is there any particular reason?
Anita Kohli has believes that there are pressurized cabins in aeroplanes.
She's absolutely right. That is the only treatment for decompression sickness as well, or prevention of decompression sickness is the use of pressurized cabins. Very good.
Rita and Padmini also believe that the same thing. Yes, well done.
Okay. Now, we have established the concept of alveolar ventilation. Let us move to the another very important part. How does the gas is transported from the trachea to the alveolus? Now, we have seen that the bulk movement of the air occurs because of Boyle's law. But once the air enters the tracheal bronchus, this is a very important step of evolution, I think. As the air enters the trachea and there is branching trachea bronchus, branches into bronchioles, and there are so many bronchioles, lots and lots, up to 23 generations of branching is seen. Now, here, the important phenomena or important principle that comes to our help is Bernoulli's principle. Now, because of Boyle's law, the air enters the trachea. Now, once it reaches the bronchioles, what happens? The volume of the volume of air increases because lots of branching and branching of terminal bronchioles is seen. Now, because of the increase in volume, there is sharp increase in pressure because of decrease in volume. Now, here, what the Bernoulli's principle says, as the velocity of fluid through a tube increases, the resulting pressure exerted perpendicularly by the fluid decreases. Now, here the opposite is happening. The pressure has actually increased. So what happens? The velocity of the inspired air actually decreases. This is a very important aspect which happens because this helps in diffusion of gases. So there is progressive increase in cross-sectional area through multiple generations of alveoli, which results in sharp drop in volume and decrease in velocity of inspired gases. So the velocity of the gas that is actually entering the alveolus is lower than the diffusion rates of oxygen and carbon dioxide. This is a very important phenomenon, and it is one of the aspects that actually makes this system, pulmonary gas exchange system, very efficient as well, because it takes hardly the length of one-third of the capillary to have that gaseous exchange. The diffusion is so fast because the velocity of the gas is almost zero here at the alveoli. Now, the transport of gases occurs by two mechanisms in lung. Now, we have seen the laws which govern the influx of air. Let us see how the transport of gases occur in lungs. It follows two important, there are only two important transport mechanisms that occur. One is convection, which is seen in the conducting zone and which allows the bulk flow of the gases. Second is the diffusion, which occurs in respiratory zone. So we have seen that diffusion is the important process which is responsible for pulmonary gas exchange, while convection occurs in the conducting zone only. Now, oxygen moves into the blood while carbon dioxide moves out of the blood into the alveoli. And this is what is known as the external respiration because it is in contact with the external environment. Now, when this exchange occurs at the level of tissues, it is known as internal respiration. Now we come to the second important phenomena that occurs in lung, that is diffusion. So we have seen ventilation, various aspects of ventilation. I have not covered respiratory mechanics. Now we come to diffusion part. Now let me introduce a very important concept, that is the partial pressure of a gas. What is the partial pressure of a gas? It is the pressure that is exerted by an individual gas in the mixture. Now, the whole of the diffusion is actually governed by the partial pressure of the gas that is dissolved in the blood. Now, what are the determinants of diffusion across the alveolar membrane? This is very important. The surface of the membrane, which is normally about 100 meters square. Alveolar pressure difference. Now, what is the alveolar pressure difference? It is actually the difference of pressure in the alveolus and the artery. Solubility of the gas and alveolar membrane thickness. If the surface area of the membrane is large, the diffusion will be more. If alveolar pressure difference is more, again diffusion will be more. Solubility of the gas is high, again diffusion will increase. If the alveolar membrane thickness increases, diffusion will decrease. Now, this is what happens when there is pulmonary edema, or there is fibrosis, as in COPD we see, or interstitial lung disease. There is the alveolar membrane thickens and hampers the gaseous exchange. Now, this diagram shows the partial pressure of oxygen and carbon dioxide at various levels. Now, we can see here that the blood entering the alveolar capillaries actually have a PaO2 of 104, while when it reaches the this blood reaches the level of tissue, here the oxygen is given and carbon dioxide is picked up. So the level oxygen content decreases Hence, the PO2 is about 40 mmHg in veins, and PCO2 is 45 millimeters of mercury. This phenomenon is just reversed in the lungs again. So we have covered few important aspects of diffusion. I hope it is clear to you. Now we will start with perfusion. Now, what are the characteristics of pulmonary vasculature? They are very important differences in pulmonary vasculature which helps in gaseous exchange. There are 5 to 10 fold less, it has 5 to 10 fold less pressure than circulation, than systemic circulation to be precise. Vessels are shorter and wider. So what happens? The pulsatile blood flow in capillaries is seen as opposed to continuous flow that is seen in systemic circulation. So there is less hydrostatic pressure. So capillaries are can be sufficiently thin for gaseous exchange. So if the pressure in the pulmonary circulation would have been high, the capillaries which we have in pulmonary circulation in the lungs would not have been able to withstand that much pressure, and there would have been leakage. So to prevent all this thing, the pulmonary vasculature has less pressure than systemic circulation. Now, there is one important paradox as well. The pulmonary arteries actually carry deoxygenated blood. Now, this distribution of blood flow is not uniform in all parts of lungs. It actually depends on gravitational factor and non-gravitational factors. So here we come to the west zones of lung, which actually defines the principle of perfusion to an alveoli based on pressures, mainly because of gravitation. So west is defined actually 3 zones. I won't go into the details of this much, but it is mainly dependent on pulmonary artery, pulmonary vein, and alveolus, and they're easy to understand, nothing much to see. 4th zone also has been identified, where there is decreased perfusion due to lung compression because of gravity. Now, these pulmonary artery in the zone 1, actually the pulmonary artery pressure, pulmonary alveolar pressure is more than that of pulmonary artery and vein. Hence, the ventilation is more in the zone. Now, the zone 2, where there is ventilation is in zone 1, there is no blood flow actually, because the arteries and veins collapse because of higher alveolar pressure. In zone 2, there is moderate airflow. What happens in zone 2 is that the pulmonary artery pressure is actually more than pulmonary, actually more than the alveolar pressure. So what happens? The alveolar pressure during systole, the alveolar pressure is more than this arterial pressure increases. The venous pressure actually increases more than alveolar pressure, and there is blood exchange, gaseous exchange. But in the during diastole, there is no gaseous exchange. Now, zone 3, where there is the greatest blood flow, the ventilation and perfusion, they match adequately. So this is the concept of west zones of lung, and they are important. We see them regularly. Now, 4th zone is where there is decreased perfusion, which is at the bases. Now, here we come to an important concept of hypoxic pulmonary vasoconstriction. Why I have included it here is that this is one phenomena which is directly linked to perfusion, and it helps in reducing the ventilation-perfusion mismatch. Now, it is a homeostatic mechanism which is intrinsic to the pulmonary vasculature. Now, constriction of intrapulmonary arteries occur in response to alveolar hypoxia. There is diversion of blood to better oxygenated lung segments because of HPV, and it causes optimization of ventilation-perfusion matching and systemic oxygen delivery. Now, why is it important to us? Because inhalational agents are known to impair hypoxic pulmonary vasoconstriction. Now, there is a short note on hypoxic pulmonary vasoconstriction that is seen often. So this is an important concept which all of you should know. Now, we have seen ventilation, we have seen perfusion. So we come to another concept of ventilation-perfusion ratio. Now, what happens, which is V by Q. Now, in the lungs, what we see is that this ventilation-perfusion ratio is actually not equal. It is not equally distributed. In the apex of the lung, the ventilation-perfusion ratio is actually 3.3. In the middle zone, it is 1, which is the maximum gaseous exchange, which allows maximum gaseous exchange. And at the bases, again, it decreases because there is less of ventilation and more of perfusion there. So in this slide, we will see what are the conditions where we see this ventilation-perfusion mismatch. The first thing that we see here is the alveoli. Now, if the ventilation and perfusion is perfect, which is approximately 0.8, what we see is the alveoli perfused and ventilated properly. Now, if the ventilation is less, but lungs are perfused, which happens, that is shunt perfusion, which we see when the endotracheal tube is in mainstem bronchus, or for that matter, in one lung ventilation. The other lung is absolutely devoid of ventilation, but there is perfusion. So in this case, what happens? There is no gaseous exchange because the fresh gas is not present. So again, this constitutes dead space. The other side of the picture is the high ventilation-perfusion ratio, where the dead space ventilation occurs because alveoli are ventilated but not perfused. This is what we see in cardiac arrest, in hypotension, embolism. There is ventilation but no perfusion. Now, the adjacent picture shows the various diseases in which we see ventilation-perfusion mismatch. See emphysema, there is fibrotic lung, pulmonary edema, and asthma. The important thing is that the fluid pulmonary edema, where the fluid in interstitial space actually increases diffusion distance. So arterial PaCO2 may be normal due to higher carbon dioxide solubility, but the exchange surface, but the diffusion distance, because of increase in diffusion distance, there is low oxygen. Now we have covered pulmonary gas exchange part. I hope it is clear. I have, because of time constraints, I have to reduce certain things, but I have covered 3 important aspects of pulmonary gas exchange: ventilation, diffusion, perfusion. Okay, now we will come to the transport of oxygen via blood. So once the diffusion of oxygen occurs from alveolus to blood, we can see this in this diagram. From the alveoli, the blood oxygen enters blood and reaches the tissues, and from the tissues, carbon dioxide is picked up and is delivered to the lungs again. Now, oxygen is actually transported in 2 forms. One is bound to hemoglobin, which is responsible for 98% of the transport. The other is dissolved in plasma, which is 2% of the solubility. The solubility of oxygen is actually very less. Only 3 ml of oxygen is dissolved in blood. So the bulk of the oxygen that is transported is in the form of bound hemoglobin. Now, one hemoglobin molecule actually binds to 4 oxygen molecules. Percentage of binding sites occupied by hemoglobin. Now, there are certain terms that I need to introduce before I go for any further. Now, the percentage of binding sites actually which is occupied by hemoglobin is known as oxygen saturation. And this is what we see by pulse oximetry. Now, each gram of hemoglobin actually carries 1.34 ml of oxygen, which is the oxygen combining capacity of the blood, so of hemoglobin. So 1 gram of hemoglobin can carry 1.34 ml of oxygen. Now, the maximum value of oxygen that blood can carry is known as the oxygen carrying capacity, which is normally 20 ml of oxygen per 100 ml of blood. Another important aspect is the partial pressure of oxygen in blood, which is PaO2. Now, these are the very important terms that should be kept in mind. Oxygen saturation, oxygen combining capacity, oxygen carrying capacity, and partial pressure of oxygen. So partial pressure, when we talk about partial pressure of oxygen, it is the soluble form that we are talking about. This is to be very clear. Now, the sum of hemoglobin bound and dissolved oxygen is actually the oxygen content, which is symbolized as CaO2. Now, it can be calculated by the formula as you are seeing in the screen. Another important aspect is the delivery of oxygen, which is dependent on cardiac output and the oxygen content of the blood. So, oxygen content of the blood actually decreases in cases of anemia, methemoglobinemia, and carbon monoxide poisoning. These are few examples that I've cited. What important thing that has to be remembered is that the oxygen content of the blood decreases. That is mostly the hemoglobin bound. In these cases, it is mostly the hemoglobin bound oxygen that is decreased, and dissolved oxygen may remain the same. So you may find that partial pressure is actually okay, but the saturation may reduce. Now the hemoglobin, as we have seen, bounds to 4 oxygen molecules. Now this is what is known as the sequential model of cooperativity, which is also known as Koshland hypothesis. So when the hemoglobin is deoxygenated, it actually exists in a taut state of hemoglobin, which is known as the T state. Now this T state is actually it gravitates towards carbon dioxide more. It has affinity for carbon dioxide more. Now, but what happens when the blood reaches lungs? The oxygen is abundant there. So it picks up oxygen in this taut state, picks up 1 oxygen molecule. Now, as soon as it picks up 1 oxygen molecule, the conformation of the hemoglobin changes, and then it facilitates the combination of second oxygen molecule. This process is repeated till the full 4 molecules are actually bound to oxygen, bound to hemoglobin, which is the relaxed state. Now, this relaxed state is actually, it has more it has more of affinity for oxygen. Now, and it is this step or this sequential model which results in the observed hemoglobin sigmoid shape of the hemoglobin dissociation curve, hemoglobin binding curve. Now, what we see here is that if suppose there is only the T state binding curve, which is a straight line. So as the partial pressure of oxygen will increase, the binding of hemoglobin will increase. As opposed to this, when there is R state binding. Now this R state binding, as we know, is more actually more has more affinity to oxygen. So we see a sharp increase in oxygen binding. Somewhere in between lies the actually observed hemoglobin binding curve, and it is because of this binding. It is because of the binding of 4 oxygen molecules by the hemoglobin. Now, what are the factors that affect oxygen dissociation curve? This is a very important topic for anesthesiologists. Now, what are the factors that affect oxygen dissociation curve? We can remember it by the acronym CADID, mnemonic CADID. C stands for carbon dioxide, A for acid, D for 2,3-diphosphoglycerate, E is for exercise, and T for temperature. The Bohr's effect actually describes hemoglobin's lower affinity for oxygen, secondary to increase in partial pressure of carbon dioxide and decrease in blood pH. So what happens as soon as the partial pressure of carbon dioxide increases? This is what we see at the level of tissues. as soon as the PaCO2 increases, there is drop in blood pH, and because this drop in blood pH lowers the affinity of hemoglobin to bind the oxygen, and oxygen dissociates from the tissues. So this effect, this is the Bohr's effect, and is very important for us. How? Now what happens? One important concept that I meant to introduce here is that the FiO2 part. Now what happens? We keep on increasing our FiO2 in the and we think that probably the oxygen content or oxygen reserve, oxygen content of the blood will increase. But what happens as the FiO2 increases? This sigmoid shape of what happens? The curve actually operates on the plateau level. So what we see is that a further increase in FiO2 won't increase the oxygen saturation much. It won't be of much help. Similarly, what happens in anemia is the oxygen, hemoglobin itself is not present much, although the PaO2 will be high. It may remain so. It will help, but still the oxygen content of the blood may be low. Now, again, now we come to the final topic, that is transport of carbon dioxide in the blood. Now, this transport of carbon dioxide actually occurs by three means, which is dissolved gas, which occurs, which is responsible for 5% of the exchange, bicarbonate, which is 98%, and carbaminohemoglobin, which is bound to hemoglobin and other proteins, which is 5%. I've missed one food for thought for all of you people. Let me go back. Just a second. I think you people will be able to answer. I just wanted to know, see, this branching has actually helped in increasing the surface area or increasing the gas exchange. So what will happen when you go for pneumonectomy? What happens for pneumonectomy or one lung ventilation? Can anyone answer? I have just missed that point. I'm so sorry. I should have asked at that time. I missed actually. So should I continue or stop here?
No, we can
Wait for the students to answer, because continuity is lost, I think. I just remembered here, okay, I forgot to ask this important aspect. What will happen if we go for pneumonectomy? What happens in the patients of pneumonectomy actually? Because we have reduced this much of branching, this much of area for the velocity of the air to drop. So what will happen?
all students are encouraged. Yes, there is Aditya. Dr. Aditya believes that there is increased space, so the others lobe will expand. I believe he means compensatory hyperinflation, like
hyperinflation. That is true.
Yeah.
That is one important
happens
aspect that happens.
Long term, yeah.
And that also increases the volume of the remaining lung. So that helps. Besides, there is one important another aspect, that is there actually increases the alveoli, recruitment of alveoli.
Dr.
So that
Hari,
increase in recruitment of alveoli increases the oxygenation.
there is a point by Dr. Harish Naik. There is a Quanda effect. Air enters into the functioning lungs, so also lungs west zone will change. That is what he believes.
Yes, exactly. That is what
Yes.
I wanted to know.
Well
Okay,
done.
fine. Should I continue?
Yes, ma'am.
I'm so sorry, I broke the continuity actually.
No, it is good, ma'am. That slide was very important also. The Bernoulli's slide and the gas exchange is very interesting.
So I will move on to the transport of carbon dioxide in blood now. Did I miss anything in this transport of oxygen? I don't know. I had prepared one. Okay, let us move on to transport of carbon dioxide in blood. Now, what happens? There are three ways in which carbon dioxide is transported in blood. 5% of it is in the dissolved form. 98% of it is taken up in the form of bicarbonate, and 5% in the form of carbaminohemoglobin bound to hemoglobin and other proteins. Now we can see this very clearly in this diagram. So this, the upper arrow we see here is the dissolved carbon dioxide, this one. Then in the RBCs, we have an important enzyme, that is carbonic anhydrase, which causes the reaction, which actually combines carbon dioxide and water to form carbonic acid. Now, this carbonic acid is a weak acid which dissociates into bicarbonate and proton and hydrogen ion, actually. This bicarbonate, as soon as this bicarbonate is generated, now what happens? At this point, I would like to introduce the concept of Le Chatelier's principle, which states that if a system at equilibrium is actually subjected to a change of pressure, temperature, or the number of moles of a component, there will be a tendency for a net reaction in the direction that reduces the effect of this change. So there is an what we do is we inherently resist any change in the present state. So this is not only true for the gaseous exchange, this is true for us as well. We also resist any change in the normal routine. So this is what happens, and this is what Le Chatelier's principle states. Now what happens, as soon as this carbonic anhydrase generates carbonic acid, it dissociates into hydrogen ion and bicarbonate. Now this bicarbonate actually diffuses out of the RBCs and is replaced by chloride, which is known as the chloride shift. Now, as this bicarbonate goes out, this proton or this hydrogen ion is picked up by the deoxyhemoglobin, which has higher affinity for carbon dioxide or hydrogen ion, actually. Now, this causes release of oxygen, the oxygen that is bound to hemoglobin, and it diffuses out of the RBCs to the tissues. And this carbon dioxide is actually picked up by this reaction. So what happens is venous blood gets higher concentration of bicarbonate and a lower concentration of chloride. So this is the carbon dioxide dissociation curve. It is, as you can see, is more linear and steeper as compared to oxygen dissociation curve. Now, oxygenation of blood in the lungs displaces carbon dioxide from hemoglobin, increasing the removal of carbon dioxide, which is actually the Haldane effect, which is opposite of the Bohr's effect. So Bohr's effect actually increases the utilization or increases the transport of oxygen from lungs to tissues, while Haldane effect releases oxygen at the level of tissues and picks up carbon dioxide. So deoxygenated hemoglobin has a higher affinity for carbon dioxide, as it is a better proton acceptor than oxygenated hemoglobin. I think I have covered the various aspects of this transport of oxygen and carbon dioxide. So thank you very much. And I'm sorry if I had missed some important concepts, because in 50 minutes, it is very difficult to summarize all the aspects of. I have definitely left out respiratory mechanics because it is an entirely different, separate topic and can be covered in one of the PG classes. Now, any questions?
Yes, Sadhana ma'am.
Thank you, Dipti. Yeah, thank you, Dipti. You have covered almost everything of the gaseous exchange and especially the oxygen and carbon dioxide, and beautifully explain all the laws which are very important for us. And this physiology of the respiratory system, basically what exactly, not the exchange of gases, which is very important for us and for it's a basic learning for all the PGs.
Thank you so much, ma'am. Thank you.
Any
questions
from the PGs? Please write on the chat box.
Yes, ma'am. There is one question there. He wants to know. He wants you to explain the Koshland hypothesis just one more time.
Okay, I will go back to that slide. Actually, what happens in this is actually sequential model of cooperativity, which states that what happens, there occurs a conformational change in hemoglobin as soon as it starts binding oxygen. So when what happens, it is in a taut form. That taut form is strongly favored in when the is favored at the level of tissues. When it reaches lungs, what happens, there is abundance of oxygen in the lungs. Now, as soon as the oxygen, partial pressure of oxygen is very high, this taut form, it what happens, there is certain some amount of conformational changes which leads to binding of one molecule of oxygen. Now, as soon as one molecule of oxygen is bound, there is again a conformational change in hemoglobin, which results in binding of the second oxygen molecule. Again, this phenomena is repeated, third oxygen molecule is bound, and finally the fourth one. As soon as the fourth oxygen is bound, the second oxygen is bound, R state starts, the hemoglobin starts achieving that R state or the relaxed state. And finally, when all four oxygen molecules are bound, it forms it becomes the R state, that is the relaxed state of hemoglobin. And it has picked up almost all the oxygen. So yes, I have forgotten to say that actually this pulmonary gas exchange is so perfect that almost 100% of the hemoglobin is actually saturated normally, not in diseased condition, but in normal conditions. I think
this Koshland hypothesis, actually it means that oxygen is bound one by one to the hemoglobin. It's not that all four are bound at one time. That is what exactly the meaning of Koshland is. Because when we are reaching from one state to another state, it is one oxygen molecule which has been bound to the hemoglobin, and then the next one. It's not that all four get bind at one time. That is what it means.
It is this process that is responsible for the sigmoid shape of the hemoglobin binding curve.
Right. There was another question which was coming up. Can you please explain the oxygen cascade?
Oh, that I haven't included.
Yeah, you are not included.
I could have.
Yeah.
Okay. So oxygen cascade is basically this. I have not actually included in a separate slide, but this is what happens here. What I have shown. Just a second. Yes. No, this is carbon dioxide.
Carbon dioxide. Before this.
Now here, what we see is that what happens when it is also called oxygen flux. So it is basically responsible for transferring of oxygen from lungs to the tissues, this oxygen flux. And this is what we have been seeing in this whole slides in this process. I have not included that oxygen flux separately, but this is what happens in the in oxygen flux, that since there is higher partial pressure of oxygen in the lungs, the oxygen is picked up by the blood. So there is diffusion of oxygen from lungs to the blood, and it is transported from blood to the tissues in the form of oxyhemoglobin bound to hemoglobin, and and in the dissolved form. Now what happens, as soon as it reaches the tissues, again the oxygen, what happens, the partial pressure of oxygen drops. So there is this oxygen actually which has affinity for more for this for proton, for this hydrogen ion. Because of higher affinity of hydrogen ion of this deoxyhemoglobin, it releases oxygen there at the level of tissues, and it picks up carbon dioxide, and the more and more carbon dioxide reaches the blood. I think I should have included that chart. It would have been good.
That. Okay, but you can still, you have explained it well.
Because
Is there
oxygen
any
flux is
query with
actually
this?
this whole phenomena is called the oxygen flux. What I have covered in the slides.
Okay, any more queries?
There is one by Dr. Aditya. In the transport of gases, we say that the velocity decreases in the bronchioles and alveoli, which help in the diffusion of gases.
Yes.
So he believes when there is an increase in the respiratory rate in ventilator, does the velocity of gas changes
This
based
is
on the
what is to
Bernoulli's
be
principle?
taken care of during mechanical ventilation. I have mentioned that this process is actually very efficient. Only 1/3 length of the capillary is required and the diffusion process is complete. Now, what happens when you are doing mechanical ventilation? Probably the pressures may be more, whatever it is, the respiratory rate may be more, or during exercise. What happens when there is when the depth of respiration increases, rate of respiration increases? What happens? This velocity will not reduce as much, but the capillary length is still remaining. It is only the 1/3 of the capillary length that is required in normal state or resting state. But when there is exercise, when we are mechanically ventilating, that length is actually increased. Okay, matlab oxygen transfer can occur at larger length of capillaries.
Capillaries.
Yes. So this system actually helps in oxygen transport during various stages, at rest, during exercise, during mechanical ventilation. I hope I have answered the query here.
Yes. So, ma'am, all the participants are currently muted. What we'll do is at the end of the talk, we'll allow them to unmute themselves so that they can ask the questions themselves if they feel.
Okay.
Nishant, I've already allowed everyone to unmute and they can directly ask the question on screen also. I've already given the power to them to unmute themselves. They can come.
Yeah. Sadhna, ma'am, there's another question.
Is there any question? I can't see anything actually.
Okay,
I have not seen.
there's a question by Dr. Prasad Bhatt. Can a patient go for hypoxic injuries in spite of good saturation during heavy blood loss? So
yes, that is what I've said. That is what happens. Now I will go back to that oxygen dissociation curve actually. Now, can you repeat the question, please?
Yes. Can a patient go for hypoxic injuries in spite of good saturation during heavy blood loss? Suppose there's been a heavy blood loss, can there be hypoxic, I believe, cerebral injury despite a good saturation of the hemoglobin?
Yes, it can happen. Now, why? Now, as I have shown this thing, there are various actually terms that we use. Now, so oxygen saturation, which is actually the binding sites of the hemoglobin. Now, we know that 98% of the oxygen is transported in the transported bound to hemoglobin. And what we see in the form of PaO2 is actually partial pressure of oxygen, or that is the dissolved oxygen. Now, what happens when we keep on increasing the FiO2, like when we are mechanically ventilating the patient, or when there is heavy blood loss? Our usual, what we usually do is that we increase FiO2. Now, that increase in FiO2 actually helps to a certain extent. But what happens after some time? The hemoglobin dissociation curve actually operates on that plateau level. That is, it is maximally saturated. Now, because of blood loss, the hemoglobin content has decreased, but you are giving high FiO2. It will compensate for certain time. But what will happen? The hemoglobin content eventually is less because of heavy blood loss, and it is fully saturated. Although it is fully saturated, but the content itself has decreased. So what will happen? Their hypoxia can actually occur. Even though your FiO2 is very high, you are giving 100% of oxygen, you are doing everything, still hypoxia can occur.
Ma'am, shall I add something to this?
Yes, please.
Sir.
Yeah, actually, this is a very good question. If you ask in a clinical format, the saturation is just reflecting, the pulmonary gas exchange only. It is not signifying the tissue hypoxia, the microcirculation, and other factors associated during surgery, the accumulation of metabolites, which may affect the microcirculation as well as the tissue oxygenation.
Oxygen. Okay.
That, according to Bohr dissociation curve, the plateau level has almost reached. The content of the HB, as you already explained, is less, and there's a massive blood loss. It's not just the saturation which is going to be significant in deciding the tissue oxygenation. You have to
Hypoxia.
include other vitals part of the hemodynamic parameters, the pulse rate, the mean arterial pressure, and whatever. If you have an advanced center, you are going to monitor the beat to beat variation of the blood pressure, the capnography. So many things are there. So saturation alone is not a deciding factor which can you can assure you or pseudo assure you that the tissue oxygenation is going in a good manner. So it is just an indicator, but it has to be correlated clinically with the other factors happening at the same time. That is what I want to say from my side.
And
Yeah.
one more thing, actually, I want to add is that the whole of this transport actually is perfusion dependent rather than ventilation dependent. So
Yeah.
what you have said is absolutely true. So there are various other factors that come into play. That is perfusion.
Any other question, Nishant, is there?
I don't see any other questions, sir.
You can invite the people if they want to ask the question directly also, no?
Yes.
How to unmute themselves.
Please
all the
unmute.
listeners are encouraged. Yes. All the listeners are encouraged to unmute themselves and ask any question from ma'am. Dr. Prasad Bhatt, if you if your question was answered, you can or
You can encourage our teachers to say that, thank you, ma'am. You can always say that.
yes.
A teacher always wants some appreciation from the students.
Yeah, that is true. That is true. And she has taken so much of pains to explain everything.
Yeah.
She really.
Actually, I'm disappointed. I missed that oxygen flux.
It's okay. It's okay. Something has to be missed so that it has to
I
be
will,
asked.
I will come to that later on. I will come to that later on, ma'am. Don't worry.
This is a topic we can go on till tomorrow also.
Yeah.
Exactly. Matlab, I had to read and I had to summarize everything in such a short period that it was very difficult.
But
That's
since
why it was
you
given
have
to you.
taken, you have carried away many of the things. Actually, you have taken up so much of pains to make it in an elaborative one.
Thank you so much, ma'am. Thank
We are
you.
just getting only thank you. No other
No,
questions
that's
are
good.
coming up. I
Actually,
think.
now I will this one supplement and compliment Dr. Dipti and Sadhana, ma'am. The reason behind this class is the more we are going into it, it's becoming more evident now. Everybody is not perfect. Suppose I'm teaching at Patiala, ma'am, Dipti is teaching at Indore, somebody is teaching at some other place. We are never exposed to the teaching skills of other teachers.
Yeah, that is true.
And
That is true.
during these classes, if you go honestly, it's not just for the PGs, for the teachers also. You see the good teaching part, the good teaching skills, some aids which you can always imbibe in your teaching methodology or manual when you are teaching in your own institution. Now, these things will go a long way in improving the teaching pattern of our country, where the even the teaching format is not universal in every institution. Everybody wants to try to teach in their subjective manner. But I think during the end of 3 4 years of these classes, we will be arriving at some common platform where our teaching methodology will be a notch
Common
higher,
to
and much better way
Standardized.
to at least each student. And the students are lucky that they are exposed to the best of teachers. During, suppose ma'am Dipti was very honest in confessing that I missed that thing. I think how many teachers really do that in the class? So it's a very interactive session type of picture in these classes, where the teachers are directly dealing with the students, and open questioning. Many of the students don't question during the class. They are
That's true.
afraid. And here you can always ask a question to any teacher, and the teachers are bound to answer. And these things will definitely help in teaching our programs of the PG curriculum in the coming days also. And
That's true.
whatever the principles we are teaching, so this is a very basic physiological principle. But when you pass out from the PG courses, you forget these things. These are just a part of your question and answer, long question, long case, short case, or long answer, short question. What happens when you are dealing with the complications during your lifetime in a clinical format? Suppose a cardiac arrest. The board dissociation curve doesn't cross your mind. You just want to, revive the patient. But when you revive the patient, if you apply these basic physiological knowledge clinically, you can produce a better results. That's what is the meaning of these basic classes. They are really something which we forget after passing out of the PG examination. So these has to be practiced. So I think the Dr. Dipti has covered very well about everything. Definitely the time
Thank
yeah,
you so much, sir.
definitely.
Thank
Yes,
you,
yes.
ma'am.
Time
definitely-
constraint is always there. It is a very long topic, basically. To cover up
Yeah.
in 50 minutes, she did a good job for that.
Thank you so much, ma'am. Thank you, sir. Thank you for this opportunity, I should say.
Ma'am, you can stop sharing your screen and we can allow one or two questions from the audience. You can stop
Okay.
sharing the screen, Dipti ma'am.
So there is one more question by somebody from with a Samsung flip phone. If the saturations do not show us oxygenation at the tissue level, then how can we assess adequate tissue oxygenation intraoperatively?
Can you repeat the question, please?
Yes. If saturations does not show us oxygenation at the tissue level, then intraoperative, how can we assess adequate tissue oxygenation? I believe he wants to know how do we assess the adequacy of tissue oxygenation intraoperatively?
I would rather say we actually judge the tissue oxygenation by capnography now. When we go to the tissue level, it is the carbon dioxide which is actually playing a major role. So we judge that oxygenation is proper by the carbon dioxide curve as well. And what happens now, if the oxygen content, what we are doing, the oxygen content is reflected by pulse oximetry. So that is also a standard monitoring that we are doing. So that also reflects the oxygenation at the tissue level.
Yeah, many times what happens, ma'am, if there is hypoxemia or there is anaerobic respiration, we can assess lactate also. That is the measure.
That is what
At the
Dr.
tissue
I think
level, we can measure
ABG is
lactate as well.
ABG is one of this thing we
Yeah,
can
that is a
have by
definite-
That we can do.
Yeah. Anything
So,
else? Yeah. I think we
everybody
are
is
done with
welcome to
that.
ask any one or two questions. We have still got a time to at least corner Dr. Dipti ma'am here. Anybody can ask the question.
Now Dipti is feeling relaxed basically after giving the lecture and answering so many questions. She's actually feeling relaxed.
You are teaching,
Yes, ma'am. True.
you are teaching the
Actually,
audience
I
of a
was
national level.
worried. Yes, yes, sir.
You are teaching the audience of national level where the
Yeah,
teachers
yeah.
and students are there. Definitely the butterflies are always in the stomach for teaching.
That is true.
True,
That is
true,
true. That
true,
is what I
sir,
was
true.
telling her. That is what I was telling her.
Hmm.
Okay.
I think everybody is satisfied with her lecture now. Nobody has any question.
It's still available on the online also. It will be
Yeah.
available so
Yeah.
that anybody, students can watch it anytime.
Right.
Because it has to be read again and it has to be seen again so that they can able to understand the concepts much better in a concrete manner.
Right. So should we wind up?
We have to take permission from Nishan.
Sir,
Nishan?
when you are
Dr.
here,
Nishan?
who am I?
No, I'm the guest.
You are the moderator of this.
Sir, this is sir's class. Sir,
Yeah, I know that.
Absolutely.
No, I really, first of all, just last comment from my side. I really thank all the teachers as well as the students who have joined these classes till date. And I feel, I request them that you can always encourage your colleagues, the teaching colleagues as well as the students to attend these classes because we will
They're
be
very important.
we will be modifying, we will be discussing certain new things also, and we will be putting, last time also I said, give your feedback so that we can improve these classes further. And there is no dearth of improving. There is no, sky is the limit. And I think we are learning like anything from all the teachers there. and it definitely going to improve our teaching skill, the clinical acumen, and so many things during these classes. So I request everybody to be actively participating and encouraging their colleagues to log into these classes. If live, you can always clear your doubts also. That's what I want to say.
That's true.
Namaste. Ma'am,
Thanks.
hello.
Thank you so much.
Thank you.
Good night.
Thank you. Thank you, sir. And thank you, ma'am. Thank you so much.